This is Joanne Geer. I'm the Executive Director of the Westchester Biotech Project, and welcome to our webinar on implementing the volume to value initiatives. This has an outgrowth from our virtual roundtable on government relations. This started last fall. It took us a while to kind of think through what some interesting ideas would be to clarify. We had a post-midterm update last fall, and this session I'm very excited about. Andrea Ruggiero is going to talk to us about a lot of the strategies that they're implementing at the Open Door Family Medical Centers. Matt McLarnon from Capital Health Consulting is then going to give us the governmental perspective. And then after we have those presentations, we're going to start a roundtable and invite everyone on the call to participate, during which time you'll hear from the co-chairs of this roundtable, Lisa Wickens-Alteri from Capital Health Consulting and Andrea Zebrak from Boehringer Ingelheim. I should practice that. I'm going to invite my partner and co-founder, Michael Welling, to share some thoughts.
Thank you very much. Good morning, everyone, or good afternoon at this stage. And I appreciate you putting your NCAA brackets on hold for the first round of these games as we have this conversation. I'm really excited about today's conversation because it is sort of our first venture into moving a lot of our topic out of the sort of laboratory and out to the sort of front lines of care. And we're really excited to have Andrea here to help us sort of connect all those dots, and even the efforts that we've been making on the advocacy front, as Joanne has mentioned, and obviously in a large part to the support and partnership from the folks at Capital Health Consulting, trying to figure out sort of where our efforts are best served. And I think today is a great culmination of moving us to that sort of next stage of conversation and, quite frankly, impact on the community. For those of you who are joining us for the first time, Westchester Biotech Project is a 501(c)(3) that we launched, and it's still not even 2 years ago. May of 2017, we have a number of initiatives and events that we host, all geared and designed to bring folks together like today to further dialogue and collaboration and identify where there are opportunities to address challenges and again, make impact within the community. Coming up next Wednesday is our third installment of our annual Innovation in Research Symposium being hosted by our friends at Westchester Community College. I would encourage anyone and everyone to take a look at the agenda and find some time to join us. There is definitely something for everyone, and it is certainly an opportunity to showcase some of the amazing work that's being done by folks based here in Westchester. We also have a number of other initiatives underway. Our recently launched Westchester Biotech Project Europe, which is a partnership with folks over in France at the moment, designed to sort of open dialogue and collaborative opportunities. We have our Rare Disease Symposium, which focuses obviously on finding treatments and cures and helping to expedite the process of bringing treatments to patients. Our microbiome consortium and our My First Laboratory initiative as well. And of course, again, we welcome everyone to investigate and look into those different initiatives and join us where it makes sense. And of course, none of this would be possible without the support and assistance with all of our community partners, alliance partners, and participants. I'm both proud and feel sad that there's so many now that I can't get to all of them. But certainly what I encourage is if there is any name of any entity that is listed there on the screen that seems like an organization that might be of interest for you to engage with or collaborate, please let us know. We would like to make those introductions. And of course, if you're looking for resources, services, we certainly encourage reaching out to our partners and engaging them on any services that you might need. All right, so now am I turning this over to Andrea, or is there someone else in between us?
No, you got it. Nice job, Michael. Thank you so much. And I'll just add that while we're making this transition, okay, I'm going to make you presenter, Andrea, that everything that we're doing, if you poke around on our website, there's lots of good stuff there, and we're happy to talk about any of it. There's a very good archive of these kinds of programs from the past, but that these all came from talking to people in our community who stepped up and either told us this is something that we care about, help us find some experts to talk to, or some experts who said this is an idea that we'd like to share. So we very much appreciate getting to know everybody. Andrea Ruggiero, would you like to take over?
Wonderful. Thank you so much for having me and for your interest in talking a little bit about a topic that's incredibly important at Open Door. So when we're looking at, of course, the social determinants of health and how that applies to the value-based care model, federally qualified health centers are, of course, at the top of that list. They're taking care of incredibly vulnerable populations, and just like that, Open Door has been doing this level of work since 1972. Our primary focus is on prevention and wellness of the communities in which we serve, and that's both in Westchester, Putnam County, and most recently, we opened a dental practice in Saugerties because there was a lot of community need. And for most of the sites that we currently operate, we were invited into those communities because there was obviously a community need that needed to be met. As of 2017, we're still working on all of our 2018 numbers, but we had over 300,000 patient visits. 57,000 patients are served annually. We currently have 6 health centers, 7 school-based health centers, and 2 mobile dental units that travel between the schools and also go to some of our community-based organization partners to kind of, meet some of our needs of our patients who can't necessarily come to the clinics to get dental services. And in 2017, we delivered 566 babies. That's a very important fact for us. So as I was mentioning, we've been around since 1972, and that's a very special picture that we always show. That's the Sing Sing Correctional Facility here in Ossining. It's the second oldest prison in New York State, and of course, we, hold it very near and dear, and we partner with them as well as folks come out and get reintroduced into the community. So as this map kind of shows, we are all over, and we serve patients from across the area. We have folks who come from all areas of Westchester and Putnam counties, and we provide really high-level quality care to all of those folks across Westchester and Putnam County. Here's just a little picture of what our sites look like, including our mobile dental van that we're very proud of. And so today, we really wanted to talk a lot about why are social determinants of health so important in the healthcare conversation right now. And so, federally qualified health centers, as I mentioned before, they're focusing on very vulnerable populations. So at Open Door, we're mostly working with patients of low income who are uninsured or underinsured, very underserved minorities, high-risk populations, and then many, many women of childbearing age and their children. We currently operate with 43% of our patients who are uninsured, and they're not eligible for any type of insurance. 34% of our patient population has Medicaid. And then, as you can see, the distribution of the other, both private and Medicare population is much smaller. So you're really looking at 43 and 34% that are incredibly vulnerable populations that we're serving every day. So when you think about the provision of care and the social determinants of health, and we look at, volume-based versus value-based, and volume-based has been kind of a historical experience, basically a fee-for-service model. A patient comes in and they pay for their visit. And this model really was all about, how productivity, how many people can you see a year? And as we began to really focus on chronic disease management and looking at opportunities to improve people's care, we realized that we just can't continue this way. And not to mention that the expense associated with providing this level of care is just unrealistic long term. And so as we're looking to shift into a more value-based strategy, the healthcare providers are supposed to be receiving incentives for providing care for patients at the lowest possible cost. And so in order for us to do that, we needed to really modify the way that we looked at healthcare. And so, of course, the Medicaid reform came into play, including DSRIP, which really focused on the spending, Medicaid spending, and just spending of healthcare in general. And, one of the big focuses of the DSRIP was specifically around avoiding hospitalizations of, patients by 25% in over a 5-year plan. And of course, what did that mean for healthcare was that we needed to begin to look at risk stratification opportunities, right? So you needed to focus and allocate your resources to patients who really required a lot of assistance and being able to, reduce or minimize the risk associated for those patients. So at Open Door, for example, we began looking at ways of allocating those resources, kind of at what model were we going to look at? Open Door joined an ACO, an accountable care organization. We wanted to enter a Medicare shared savings program. Even though we only had about 1,600 patients, we still wanted to be at the table and engaged in those conversations around, how do we care for patients in a much more effective way. We wanted to have resources that were trained and providing really great services to our patients, but we're also able to engage patients so that prevention was at the key of all of that. When I talk to other organizations, we're trying to figure out what risk stratification tools to use. There's just too many to count. The Accountable Care Organization looks at risk through certain scoring, and they're looking to, see what costs are associated with Medicare spending. When you're looking at the American Academy of Family Physicians, you actually begin to look at things like social determinants of health and utilization of ERs and hospitals. You're looking at a lot at other things that federally qualified health centers, I think, put a lot of value on. And so at Open Door, we kind of got creative and we used the American Academy of Family Physicians, but we spoke to other community health centers and really kind of came up with our own very specific model. And this is kind of a snapshot of what we use to care for our patients, right? So we have a 70-year-old patient, a risk score of 5. The provider is Wanda. And they're, we kind of get a snapshot of the care gaps that this patient has so that a care team is put in place to essentially meet all of these care gaps and help this patient get as healthy as possible. So it is important that an infrastructure is put in place so that all of the resources can be adequately deployed. So when you're looking at the top of the pyramid, right, the integrated case management focus, those are the patients who are the most medically fragile patients, the ones that have probably the most social determinants of health that are impacting their lives. So they're really struggling to meet, their needs on a daily basis. Those are the patients that we need to make sure that we have other supports in place to be able to help the clinicians meet their healthcare goals as well. So if we're able to go, and one of the examples that I always give is that our case managers look to focus on one patient for a little bit of time. They were working with one patient who had 24 hospitalizations in 1 year. So we needed to understand what was going on that was causing this patient to repeatedly go to the hospital. And we looked at housing, we looked at food insecurity, we looked at what were her chronic conditions, what was going on. We had to get a full picture of what was going on with the patient. And after, stably housing the patient and linking them to the appropriate community-based organizations, the patient went from 24, ER visits to 8 ER visits, which were appropriate for the conditions that she was battling with. So it was really important to really understand, and at our, both care coordination, case management level, and, uniting with the clinicians and really speaking the same language and, helping to really meet some of those milestones and goals for that patient were really crucial in helping to address some of those avoidable ER visits, for example. So at Open Door, one of the tools that we decided to work with to help us really understand the needs of our community is this tool called PRAPARE. And PRAPARE stands for Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. So we, of course, just refer to this tool as PRAPARE. And PRAPARE really asks a series of questions to kind of begin to get a full picture of what might be some of the needs that our patients have and how we can help them achieve some of their goals outside of the clinical setting. And the folks who are administering the tool are patient advocates who are in the health center setting. They're really folks who help address some of the social determinants of health, but also help kind of meet the gaps in learning, gaps in knowledge that sometimes exist between what the clinician might be explaining to a patient and then what a patient is actually able to take away from their clinical session. The behavioral health integration specialists, or BHIS, as we lovingly refer to them, are these incredible master's level social work individuals who are getting their clinical hours with Open Door. And part of the work that they're doing is to assess folks for depression and anxiety and a lot of other behavioral health conditions that might also be impacting their lives and not allowing them to be successful in their healthcare. And they are also able to ask other questions like, if there are substance use disorders in their lives, and they're able to link them to services appropriately. As I mentioned before, the integrated case management program, they focus on the most medically fragile patients, and the PRAPARE is also used to figure out the appropriate care plan that can be used to help patients achieve some of those milestones. And then, of course, other care coordination program staff, they're also administering the PRAPARE. So what ends up happening is that we will either administer the PRAPARE in the exam rooms, or in many situations we'll bring them into an office if that's available, and we'll ask a lot of questions. And again, the assessment is really focused on patient-centered care. So we will meet the patient wherever they're at, and we're gathering as much information as we can about the patient so that we have that full story of what's going on. This is all documented in our EMR, or electronic medical record system, so the information is available across all disciplines. So if it's administered by a patient advocate and a behavioral health integration specialist needs information for their provision of care, they will be able to read in real time the information that's being captured and documented. And then we're able to put referrals in place for those patients to whatever services are appropriate to meet those patients' needs. So in this case, we put some examples here. So if a patient is a really good candidate for WIC, or if the patient has trouble accessing transportation, or if they need a referral to Catholic Charities or the National Diabetes Prevention Program, we are able to document all of this information so that others are able to see what needs the patients might have. This is, just a lot of information that we're capturing through the PRAPARE, but these are some of the questions that we're looking. We also kind of try to assess stress levels of our patients. And, we're looking to make sure that we're capturing as much information as possible. So in 2018, we did over 3,300 surveys through October. Most of them were done by the behavioral health integration specialists. Some were done by the medical assistants, and some were also done by the patient advocates. So one of the really interesting things that we found is that many of our patients don't necessarily consider themselves completely at need. So the ones that we want to make sure that we're capturing are obviously patients that need a lot of case management and supportive services. We want to engage them in a lot of supportive care. But we do have a good number of patients who are unemployed, and they are actively seeking work. Others we have who are disabled or the elderly, that we're just trying to link them to services and make sure that they have enough of a support system in place and that they're safe. And interestingly enough, 6% of our patients said that they feel, that they do not feel physically and emotionally safe. And so we're able to link them to behavioral health and domestic violence organizations that we partner with very closely. 72% of our patients are Spanish speaking, and that's, a large number of our population. Like I said before, 43% are uninsured and unable to apply for any type of insurance. So there's a large population of undocumented folks that we are working with and, of course, providing services as needed. So in our EMR, we're obviously able to track all of the community needs that we may need to put in place for our patients, which is really great, because at the end of every quarter, we kind of take a look and see if there are any trends, any specific partnerships that we need to develop in order to meet our patients' needs. We're also looking at health literacy. This is very big, especially around a healthcare industry. We're asking patients how they prefer to receive information about their medication or healthcare in general. And so we're looking to see if they would prefer to receive it orally or in writing or in pictures, or if there's anything else that we are able to help them meet. And we document all of this information. This is actually a specific case management template that we use so that case managers are using evidence-based questions to follow up on patients. And then we track all of the enabling services in the community as well. So we keep track of partners and organizations within each of the communities that we operate in. And this list is updated at least annually. I mean, it's a living, breathing document, obviously, as organizations come on or organizations, end up closing their doors. We need to make sure that this information is updated. So we do try to update it as often as possible to make sure that the partnerships are stable and that we really are able to respond to our community's needs. So what's interesting is that, when we were looking at some of the services that are provided through our patient advocacy program, we really were, not surprised at all to see that 61% of our patients who received some level of support through our patient advocacy program really needed help around medication and healthcare navigation. We see that this is a huge barrier to care. Many of our patients, need access to medications that are very costly. And the patient advocates are essentially working with both the 340B program, and they're also working with pharmaceutical companies to help meet some of our patients' needs, which is sometimes difficult because if they are undocumented, some of the opportunities to provide support are more challenging. Of course, as you can see, we also have a lot of assistance that's rendered around insurance. So patients have a very hard time understanding their explanation of benefits, deductibles, co-pays. There's a lot of barriers that we're looking to help address. And then, of course, issues like billing and assistance with charity care applications, which sometimes are very, very daunting, specifically with patients that have limited health literacy. And in many of the large hospitals, there's just not enough support for populations who are either, illiterate or limited health literacy. And then, of course, 5% of the time that was spent with our patients was around transportation, housing, food, and utilities assistance. So one of the really wonderful things that we've been able to do by being able to ask and assess the social determinants of health, the needs of our community, is that we're also able to put care plans and develop self-management goals with our patients. We're really able to provide a more profound impact in the way that we deliver care. If patients are really engaged in the healthcare provision, they're really much more able to have positive healthcare outcomes, right? And I think that that's really important, and why there's been this really big emphasis on value, is that if we're really able to have supportive services for our patients, we're able to invest in opportunities to, partner more profoundly, which is a really wonderful thing. And then, as we're thinking about the future of value-based care, we're looking to improve the delivery of preventative primary care, right? We want to take care of people before they get sick. So I think, there's got to be a more, profound investment in putting, guardrails around, spending, really. Folks don't want to come in and see their clinician if they are feeling well, and having patients come in before they get really sick is a key to all of this. We've been obviously partnering with managed care organizations, and they're going to be very, very important in order to help really bring the right people to the table. So behavioral health and community-based organizations and hospitals, it's really important. And one of the examples that I always like to share is that, bringing the right people around the table to discuss why all of these things are important is really, it's at the key of all this. And we have an incredible partnership with Feeding Westchester. And the reason why this partnership started was because we would ask people questions about food insecurity. And most of the time, the answers that we would get is, oh, yeah, no, I'm okay. But when we started asking more profound questions like, do you have access to fruits and vegetables? And we saw that the answers were no, they're much too expensive. So we needed to ask more questions, not just do you have enough to eat, but questions around, do you have access to the right types of foods? So when you look at the rates of obesity, hypertension, and diabetes in healthcare and how much it's costing the healthcare industry to treat these chronic conditions, but we're not asking questions around, can people prepare the right foods and have access to these foods, and our patients are struggling to pay the rent and struggling to do all of the things that they need to do. And we began to see that partnering with an organization like Feeding Westchester could have a really amazing impact on our patient population. And so at our Mamaroneck site, for example, once a month, we have a 10,000-pound truck that comes in from Hunts Point, and it brings incredible pallets of fruits and vegetables that are available for the community. and we will put volunteers in place to help distribute the fruits and vegetables. They don't have to be patients of Open Door. Open Door just happens to be the place of distribution. Many of them are patients of Open Door, but we obviously did not want to limit that, but we're able to really help engage the community around some of these initiatives. We're also able to have another program, which is this Green Thumb program, which specifically focuses on patients with chronic conditions. It is a program that, again, comes with a big bag of fruits and vegetables for our patients, but also comes with a lot of education. So our registered dietitians are able to provide some healthy recipes and do a little bit of education around lifestyle changes that can help our patients improve some elements of their daily lives. And then, we have done a lot to engage other partners to make sure that these opportunities don't go, unanswered. So I do think that there's a lot of work that still needs to be done around partnering and engaging, but, definitely the MCOs will be important around, putting together these value-based contracts and helping bring the right people to the table so that we can all do the right thing at the end of the day. So with that being said,
Wow.
thank you.
Thank you, Andrea. That was really wonderful. Matt, I'm going to change the slide, but you can go ahead and would you, actually, before we go to Matt, Andrea, would you just tell everybody what your role is at Open Door just for a moment? And then,
Sure.
Matt, if you could start with your role and continue on, that would be great. Thanks.
Yes, so I am the Vice President of Community Health, and that sounds like a funny title, but I essentially, a lot of the work that I do focuses on all of the enabling services that are rendered at Open Door. That includes care management, our WIC program, our wellness program. We have services specifically focused on exercise and keeping our patients active and moving. So a lot of the programs that I'm involved in really help to support the clinical outcomes of our patients.
Thank you very much. Matt McLarnon, welcome.
Yeah, thank you. Good afternoon, everyone. My name is Matthew McLarnon. I'm the Government Affairs and Policy Associate here at Capital Health Consulting, and I'm just going to jump right into it. My presentation is going to be just a general overview of the Medicaid program here in New York State. There will be a couple things that Andrea's gone over a little bit, but I'm just going to jump right into it so we can get to the roundtable. So the Medicaid program in New York State covers about a quarter of the state's 19.5 million residents. That spending of Medicaid services in 2008 equaled to about $77 or $78 billion, where the majority of that was spent in managed care at 60%, followed by fee-for-service payments in long-term and acute care. Since the expansion of Medicaid under the Affordable Care Act, New York has made curbing Medicaid spending a priority. In 2011, Governor Andrew Cuomo directed then Medicaid Director Jason Helgerson to lead the efforts under the Medicaid redesign team to find means of spending less per person on Medicaid. Included in these efforts were capping the growth of overall spending at the medical inflation rate and eliminating automatic annual increases in payments to doctors and other providers. One of the more prominent products that came from the MRT initiative was the Delivery System Reform Incentive Payment Program, or otherwise known as DSRIP, which Andrew touched on earlier. Announced in 2014, this program was granted a waiver to reinvest $8 billion in federal savings generated by MRT initiatives and reforms to achieve a 25% reduction in avoidable hospital use over 5 years. Also, as part of the DSRIP waiver, New York State committed to reaching 80% of managed care payments to providers using value-based payment methodologies by the end of the waiver period, which Andrea also touched on towards the end of her presentation. So just to give you a sort of layout for what the budget aspects of this year's New York State fiscal 2020 budget looks like, at the beginning of the year, the governor, Andrew Cuomo, had presented a budget that would have given Medicaid its first increase since he became governor in 2011. But due to a $2.5 billion shortfall, that was clawed back, and the Medicaid program was initially offered to lose $500 million in total budget allocation. But due to federal budget, the federal budget that was introduced last week, that has also changed, because according to the New York Department of Budget, the cut at the federal level will result in a $4.5 billion cut from funding for Medicaid and the Essential Plan in 2020, and is expected to grow to $10.2 billion in 2021 and $11.2 billion in 2022. So while the executives still initially trying to do their analysis to see where that money will now go, the current format is not likely to move forward, and furthermore does not include cuts to the federal qualified health system that impact on the Medicaid and Essential Plan programs. So while we're sitting here, the governor has also introduced the reintroduction of the Medicaid redesign team, which I touched on earlier, to find additional savings for the Medicaid program. And while federally qualified health centers health centers are attached to federal funding, they do feel the impact of cuts at the Medicaid level. So while a lot of federal qualified health centers, FQHCs, deal with budget constraints, this will only further the issues that many of them face going forward in addressing value-based payment arrangements. So just to kind of lead us into where this conversation will probably revolve around is identifying and having a discussion about FQHCs and the things that they face regarding their budget constraints, incentive alignments when establishing VBP arrangements, data management with limited resource structures, and again, even if you're putting out the best value, best product and quality of care, you're still going to have that issue of volume at the end. So that kind of brings things full circle, and I'll let this roundtable begin.
Wow, thank you, Matt. This is Joanne Gear again, and in just a moment we'll hear from Lisa Wickens-Alteri. But what I think of when I hear those two presentations is that we're really heading up a creek. And what's wonderful is that Andrea has been putting together what looks like really valuable data. And, Lisa and Matt as lobbyists, I think, it seems to me that what they've been collecting could be really valuable in making the case that improvements are improving things. You don't have to give us less money because we can improve things more with more money. But I'll let that dangle. If you want to say anything about that, you're welcome to. But I'd like to introduce you, Lisa. Do you talk about Capital Health Consulting and yourself? And any thoughts?
Sure. Yeah, so Capital Health Consulting, we actually we represent healthcare providers. We have had the opportunity and work very closely with a couple of different FQHCs in very different areas of the state. Hearing Andrea's presentation, it was excellent. I will say that it's very different from some of the other providers, her FQHC, and some of the demographics that we work with in Brooklyn and then up in upstate New York, which is above, above like Albany. So one of the things that I think is really, really important and goes back to really not only the MRT, but the volume to value initiatives is that what you heard from Andrea and where she is as an organization is much different than most of the institutions and facilities in the state, especially those that are like the hospitals. So, Andrea mentioned that historically everything's been generated on volume, and making that culture change has been very, very, very difficult, not only for the larger institutions, but for the practitioners that are out there doing what they do well, which is just care for patients. So the other piece of that's been really difficult for a lot of our clients, and not just our FQHCs, is really, understanding and utilizing data differently. It's you capture a lot of information. What does it mean? Turning it around and analyzing it, and then really negotiating with the state and/or your managed care organization to say we're saving this money, we want to share in that, is a totally different type of conversation that's ever happened in the past. So although it makes rational sense, it really is something that's been culturally shocking, I'll say, to health and human services industry. So those are just my thoughts.
Thank you, Lisa. Andrew Zebrak, would you please introduce yourself?
Sure. Thanks a lot, Joanne. So I'm Andrew Zebrak. I'm at Boehringer Ingelheim, which is a large biopharmaceutical company, and I lead within our government affairs group the team that analyzes different changes to the healthcare system and legislative and regulatory proposals. And I really appreciate both presentations. I think there's a lot of great insights into some of the concepts like volume to value that get thrown around a lot, but it's not always clear what it means or how it might benefit patients or the healthcare system, as well as some of the different legislative proposals that we're seeing come out at the state level. So I guess I would add, just from my perspective, some of what we try to work on as we think about volume and value and how we could try to lower healthcare costs and improve outcomes, because that's really the objectives that I think everyone's striving for, is we're pursuing something called value-based contracts, which for a pharmaceutical company is an agreement between the pharmaceutical manufacturer, which is us, and the health plan or insurer, where what we essentially do is we kind of guarantee that our medicine will be effective and will result in better outcomes for patients, and it'll reduce overall healthcare costs. So there's lots of ways of saying that last piece about reducing healthcare costs, but essentially we're saying that regardless of what the spending on medicines might be, there's going to be more than offsetting improvements in care and reductions in healthcare costs, like reduced hospitalizations. That was one of the topics that I think Andrea had talked about earlier. And by showing that medicines can be effective and measured with real data to show that kind of net reduction in total cost of care, it's another way to show that you could sort of enter into these value-based contracts, and through sort of these new innovative contracts and private negotiations, you can save the system money and help lead to better outcomes for patients. There's a lot of challenges in doing this. I mean, it's not a cure-all, because you have to sort of do this. We're one company and we're trying to work with lots of different insurers and plans, so you're not instantly reaching all patients or the whole healthcare system. But I think the more that we can do it, we can demonstrate the good outcomes and reductions in spending are possible. And we're trying to break down some of the barriers that are inhibiting the ability to do this. Sometimes it's just having all the right data at your fingertips to be able to measure what the impact actually is. In other cases, there's some sort of outdated government laws that kind of inhibit the ability to do this. But we're trying to commit to doing a lot more of this as a company, and I think there's interest also on the side of health plans and insurers. There's different surveys that kind of gauge their interest. So I just wanted to make those comments to express a little bit about some of the ways my organization's thinking about this movement from volume to value and how it could really benefit patients and the healthcare system.